Good day, everyone. I want to welcome you to this exciting webinar series that we are so excited about in offering today. I am Al Richmond, Executive Director of Community Campus Partnerships for Health. I'm based in Research Triangle Park, North Carolina. I am so excited to be with you today and for this session. This has been some work that's been long overdue, and that Community Campus Partnerships for Health is really excited and proud to be a part of today. Our session today is entitled Improving African Immigrant Health, the Role of Community Engaged Research and Action webinar. And as background, I want to just kind of share with you what we believe is really kind of the centering and the framing of the conversation today. African immigrants in the US are one of the fastest growing immigrant communities. Too often their experiences are lumped with the experiences of US born African Americans. Because of language, culture, the impact of migration and other factors, African immigrants have needs and stories distinctively different from US born African Americans. This discussion will provide an overview of African immigrant health. It will also seek to highlight current research and increase awareness of the need for community-led research that supports service delivery and advocacy on behalf of African immigrants. Our run of show today will include a series of presentations by researchers and community partners that are actively engaged in African immigrant health issues. We're excited to have them and honored to have them as part of our webinar today. They will facilitate a series of presentations at about an hour. And after that, we'll have a very robust and engaged conversation dialogue between you and the speakers. We encourage you during the webinar to actually chat in the box, use the chat box feature to chat in any specific questions that you have. And if you want to direct those specifically to one of our speakers, or if you would like for all of them to respond to it. Your ability to speak has been muted during the formal presentations. But again, you can use the chat feature to share any specific questions that you may have. We believe that the high number of individuals that have joined today and even have an interest in this topic is indicative of the fact that people really want to have a serious and robust conversation regarding the health needs of African immigrants. I want to take a moment to introduce our speakers today, and after I introduce them, they will have an opportunity to share with you. Many of them will present slides that will be shared with you after the session. Our first speaker today is a unique individual in that she is both a community activist, researcher, but also has the distinction of being a member of the Community Campus Partnerships for Health Board of Directors and a longtime colleague and friend. Chioma Naje is a community health worker and organizer with more than 20 years in the field of HIV and AIDS, sexual health, equity, racial justice, and immigrant health. Currently, she is a senior program director at the Multicultural AIDS Coalition, which is a co-sponsor of today's event. They are headquartered in Boston, where she leads work in research, capacity building training, and community mobilization. Specifically, she is a founder and currently directs the Africans for Improved Access program and HIV STI outreach screening and navigation program engaging Black immigrants in Massachusetts. She will also describe two projects that she is associated with and directs and leads that were funded by the Patient-Centered Outcomes Research Institute. Musolo Bukele is the Director of Health Programs at African Services and is responsible for supervision and oversight of health programs, program monitoring, evaluation, and information management systems. He has been closely involved in developing and managing African Services, HIV prevention and testing programs in Ethiopia, and is part of African Services Technical Assistance Team. He previously worked as a research assistant with the Hunter College Center on AIDS, Drugs, and Community Health, which specializes in field research, evaluation of community-based programs. Dr. Yvonne Commodore Mensah is an assistant professor at the Johns Hopkins School of Nursing and the Johns Hopkins Bloomberg School of Public Health. She is also faculty at the Johns Hopkins Center for Health Equity. As a nurse, scientist, and cardiovascular disease epidemiologist, her program of research seeks to reduce disparities in cardiovascular health among African descent populations, locally in the US and also globally in sub-Saharan Africa through epidemiological and community-engaged methods. She is co-investigator in the Johns Hopkins Center for Mobile Technologies to Achieve Equity in Cardiovascular Health. Today, we will explore research conducted with African immigrant communities that examines and addresses health inequities. We will highlight critical factors for engaging African immigrant communities in researching outcomes that have impacted the communities. Again, join us in welcoming our speakers for today. We'll start with Chioma.
Thank you very much, Al. I really, really appreciate your leadership in creating this space for us to have this conversation and ensuring, that we are really amplifying and uplifting the voice of communities and the ways in which communities are leading and are engaging in research. Again, like Al said, my name is Chioma Nnaji. I work at the Multicultural AIDS Coalition, which is located in Boston, Massachusetts. Today, what I'm going to be sharing with you is a project that it was funded by PCORI, and I'll talk about PCORI a little bit, but it's a project that is community-led and addresses HIV in African immigrants. So I'm going to give you a little overview about national data as it relates to HIV and African immigrants, talk to you about our experience in Massachusetts, and then talk about the actual project and some of our ongoing work. I want to start off by saying that, research focus on African immigrant health is fairly new. But I do have to say that, in the HIV/AIDS field, we have been, I think, collecting or identifying ways to collect more data around what's happening with African immigrants, are non-US born versus US born Blacks here in the US. And so I think in HIV, it's a good sort of template for how the work can be done in looking at other diseases, illnesses, or conditions. What we do know is, in 2008, Dr. Karani actually, put forth the first national article that really said, okay, what's going on here? And recognizing that the HIV epidemic amongst African immigrants is really a hidden epidemic, mainly because we haven't had the right data, variables to collect the information, but also because there hasn't really been any interest on a national level. And so since then, there's been some very foundational articles and work that has been put out to really look at what are some of the issues. Some of these articles, what we do know is that there is a significant difference between the experience of US born Blacks as it relates to HIV and non-US born Blacks. And nationally, we know that the epi profile looks different. So as it relates to US born folks, primarily we see an increase in HIV in the male population. When we talk about non-US born Blacks and Africans, it's female. The risk category is different. When we talk about non-US born Blacks and African immigrants, we're talking about heterosexual sex versus what the majority might be MSM are male to male sex, men who have sex with men. And then, overall, what some of the data that is out is saying that African women are actually most highly impacted when we look at non-US Blacks versus in the US population, we're talking about men who have sex with men. There's a small decline But, this is again why we disaggregate data, right? Because there might be a large decline on a national level, but when we start looking at particular populations, it tells a different story. And then late diagnoses, which is important, right? Late diagnoses means that people are diagnosed with HIV and then within 3 months they're diagnosed with AIDS. And you'll see that in Black immigrant populations, it's almost 40% versus in US born populations, it's 26%. One of the, I think, profound articles or information that's been put out in the last couple of years is really, again, looking at the importance of disaggregating data. Here you see that African-born women, African immigrant women are 5 times, at the annual HIV diagnosis rate are 5 times more likely per 100,000 population, 5 times more likely to be diagnosed with HIV in comparison to some of the other populations, particularly US born Blacks. So overall, what we do know around national data is that African immigrants are presenting with HIV and AIDS, and so they're having more of an advanced disease. African immigrants are experiencing greater HIV stigma in comparison to US-born Blacks, and African immigrants are also experiencing challenges not only around testing and care in their home country, and that impacts their engagement in testing and care here. And then also, there's a significant proportion of HIV infection among immigrants post-immigration. And I think that's very important because often when we have this conversation, we're talking about people coming from areas that have high numbers of HIV infection or high prevalence, when really what data has shown is that African immigrants, including African immigrants, are getting infected here in the US. And then we already showed that the epi profile is different. And there are other co-infections, right, in dealing with African immigrants and other immigrants too, around hepatitis B, malaria, and then also tuberculosis. So I want to ground our conversation in the work that has been happening in Massachusetts. I founded the Africans for Improved Access program, which came out of coalition work led by a woman named Rosette Saranga, who is my mentor in doing this work. And so what really happened was the state brought together some African professionals and to acknowledge that there's data showing that there was some inequities in particularly reproductive health for women, right? And the closer that they looked at that data, they saw that there was an increased new HIV diagnoses. And so they brought together some professionals to sort of see what's going on. And they actually worked with African immigrant professionals to implement a needs assessment. And at the same time, my organization, the Multicultural AIDS Coalition, got funded by CDC to really start building an agenda, a plan around addressing HIV in Black communities. And we knew because of what was happening on the ground in Massachusetts that we could not do a blanket sort of Black strategy, that we needed to recognize the subpopulations within the Black community. So we created a task force for African immigrants. Out of that work, we actually became the first state-funded program to do work to address HIV in African immigrants. And I think this is very important because what was happening locally, not just in Massachusetts, but in New York and other places, we knew that HIV was an issue with this community. And it just took a while on a national level for us to be able to pull data, identify data to really mark it as an issue that we need to address. Our program is based on 4 basic principles on the way that we interact with communities, the way that we build our interventions. We make sure that all our interventions are community-led, which is why you'll see how the research project that we did was set up in that way. We make sure that we build long-lasting bridges. It's not just about us going in talking about HIV, but it's about going in building relationships with community leaders and community organizations. We also think critically about how do we incorporate African-centered social and cultural values. We're talking about communities that have assets, communities that have values that are important and that actually support them and support them in fulfilling and wellness in their own community. So we want to build all those. We don't want to ignore it and put in Western-based practices. And then lastly, we link our services with other services. services. So in addition to HIV testing, we would do work around immigrant assistance, immigration assistance. We'll do work around how do you talk with your doctor. So it's not just sort of HIV, but other services that our communities might need. So again, what is happening in Massachusetts is HIV/AIDS among African immigrants is still an issue in Massachusetts. Immigrants are about 17% of the population in Massachusetts, and they make up about 35% of the HIV cases. And what you see here is that sub-Saharan Africans and Caribbean immigrants have the highest numbers around HIV cases in Massachusetts. And you'll see that sub-Saharan African women are mostly impacted. So we came together as a group and started a collaborative called Tulumbe. Tulumbe actually is a Luganda word, spoken, which is a language spoken in Uganda, and it means to engage. And that was really our focus, that we wanted to engage our community, individuals who are not already connected to do an HIV work, individuals who are lay folks, to really engage in finding and addressing issues and finding solutions for HIV. Here's our partnership. Our partnership is made up of academics, of community members, of African immigrant professionals, and we do have individuals who are living with HIV and impacted with HIV. And you see healthcare providers as well. So we were funded to do Tulumbe through PCORI. And I usually don't put so much emphasis on our funder, but I wanted to do it for this because I think it's very important to think about how funding impacts us being able to do the work that we want to do. So PCORI, Patient-Centered Outcomes Research Institute, is a semi-government organization that's funded directly through Congress. And they've been doing a lot of research around healthcare and clinical outcomes. They also have a very particular focus on making sure it's patient-centered, right? And so making sure that patients are not only participating in the research, but are actually coming up with research ideas, developing the methodology and the design of the research project. They want to make sure that your research teams are diverse, again, having patients there, having community organizations there, having advocates there. And then they have specific funding that is about building capacity and engagement, which is what we were able to go after in order to do our work. And it allowed us actually to be the lead, because we know that there are some funding mechanisms, most funding mechanisms out there create barriers that don't allow community organizations to actually lead in terms of what they require in terms of the PI, having experience in doing particular types of like clinical trials or clinical studies. So PCORI, this is no longer in existence, but PCORI had a funding mechanism called Pipeline to Proposals. It's a 3-tier process, which the first tier allows you to only focus on your partnership development and engaging your people, right? Engaging the community, engaging your stakeholders. Then your second tier allows you to start developing your research questions. And then the last tier was actually to support and provide technical assistance for you to submit to some of PCORI's bigger money, which is their bigger research grants. So what we did is in tier 1, we started and only focused on our partnership, right? We focused on developing our governance document. We also looked at who's around the table and who's missing, what voices were missing, who we want to bring on as part of our partnership. We named our partnership at that time. That's how when we came up with Tulumbe, one of our team, our partners, Frederick, came up with that name. And then we started talking to providers, talking to the community about what are some of the issues related to HIV that needs to be addressed through research. In tier 2, we went back to the community, got feedback based on what we came up with. We built the capacity of our partnership to really start thinking about research questions and research design. And then we focused on dissemination. Unfortunately, we were the last cohort to come through this funding mechanism. And PCORI decided to end the funding mechanism in 2017, which was supposed to be our Tier 3 year. So just want to talk a little bit about some of the information that came out of the work that we did. We did community forums. We did two, reached about 61 participants. The participants were pretty diverse as it relates to African immigrants. A lot of what came out of that was around people talking about there's so many barriers in engaging in HIV, right? HIV testing, care, treatment, education. I want to highlight, this idea around family secrets, right? We don't talk about sex. We don't talk about why people are sick. And so holding those secrets really create barriers to people wanting to get tested. Or even finding out more about how to prevent HIV. Also, the lack of visibility of Africans living with HIV, and we know that that is a challenge, right? We want communities to feel comfortable to disclose, but we also know we have to create the environment in which people feel safe. And then you see on the right side that people talked about what strategies actually worked, right? And so again, making sure that we're engaging community leaders, making sure that we are implementing strategies that normalize the sex conversation. We did a provider survey. We reached about 53 providers. Majority of them were from Massachusetts. Majority of them came out of community health centers. They were administrators, and they were providing services to African immigrants for over 10 years. This provider survey yielded some interesting information. Providers were talking about, we asked the question around what were some of the challenges or barriers that you are having in primary HIV prevention, so around outreach, education, and testing, secondary HIV prevention, then also linkage to care. And so what you see here is that stigma is really leading in all of the areas. And then you'll also see the lack of culturally appropriate HIV prevention messaging as a critical barrier or as a need in order to do the work. The providers also talked about interventions that worked, what they've done in their practice or what they've done in their community health center, and interventions that didn't work, right? And so what worked is hiring African immigrants to be a part of the team, but that also was a barrier said by some of the providers. What worked was making sure that you outreach to local African businesses and organizations, that you bring testing into the community and not expect people to come into the health center. What didn't work are the current evidence-based group level interventions that are out there around for HIV that might be focused on other populations, but need to be adapted to African immigrants. So at the end, the partnership engaged in a participatory data analysis process where we took the information from the provider survey, we took the information from the community forums, and we said, okay, what are the issues that people are talking about that we need to address in order to really get to the point of ending HIV for African immigrants? And these are the 6 issues that came up. One is a focus on youth. Another is a focus on African women around self-sufficiency and self-empowerment. Another one is stigma. The fourth one is around improving communication about sexual health within the family. So thinking about communication between the mother and the father, communication between the parents and the children, and even communication amongst children within different families. And then 5 is to reduce the impact of male dominance that is found in African communities or African families and African families. And then the last is really to focus on health literacy, building the literacy of African immigrants and understanding how to navigate the system, even understanding certain language and words that we use in HIV prevention. In Tier 2, we reported back to the stakeholders, and they prioritized 3 of the issues that we should move forward and focus on in terms of developing research questions: stigma, youth, and then family communication. And so in order for us to develop the research questions, we actually, again, engaged the partnership in building capacity. So we had a Research 101 workshop. We implemented a survey to ask community members, actually, what questions are they most interested in as it relates to these 3 priority areas. And then we did some dissemination and feedback in other ways. We presented at conferences. We presented at provider meetings happening within the state. We also did some national national webinars, and we also did some social media engagement. And so what has come out of our Tulumbe, sort of the PCORI funded component, is that we have been able to take those 6 topics that were identified as critical issues to address in dealing with HIV amongst African immigrants. We were able to take them into actually other research projects, right? So the one focused on stigma. If you remember, there was a focus on stigma. We actually got funded through our local Getting to Zero coalition to do a stigma-specific Photovoice project. So we recruited 8 African immigrants to do Photovoice, and I don't know if folks are familiar with Photovoice, but Photovoice allows you to use pictures and captions to talk about participant experiences. And this group actually decided they wanted to take their work and develop a campaign. And so we launched this campaign as part of the National African Immigrant Refugee HIV Awareness Day. The other project that we are now doing is funded by PCORI, and it's funded by PCORI's bigger funding opportunities under their Addressing Disparities. And so this allows us to compare 2 evidence-based interventions, to adapt them and then compare them to see what works for African immigrant women. And we'll be able to send you more information as a follow-up email. And so what really worked for Tulumbe as a community-led research partnership and collaborative is that we had a diverse group of people, not only in terms of stakeholders, but also having Africans from different countries. We had people who were passionate about the work, right? And so people could talk about it from personal experiences. So we knew that they were committed beyond sort of funding. We made sure we had ongoing engagement of African immigrants. So throughout the time that we were doing the project, there was always an iterative process with our community. We knew that building the partnership was going to require time. And again, this is why the funding was so critical, because that whole first tier allowed us the time to build our partnership and gave us the funding that allowed us to do that. We wanted to also, and through that, we were able to incentivize our community members and participating not only in the partnership, but also participating in advocacy and education opportunities. What was challenging was the recruitment of community members, because folks have lives, right? They're doing stuff outside of HIV. And so it was hard to recruit community members. And so we just recognized that people are going to come in and out, and we just needed to be committed to making sure that community members were there in the space. We didn't have, in moving forward, it was difficult to have adequate funding to carry out projects. African immigrant health is not on sort of a national radar. And so being able to really advocate that with funding opportunities, advocate a focus on African immigrant health and HIV with our stakeholders locally in Massachusetts has always been an uphill battle. And then also finding time for people to meet. Of course, all of us have busy lives. And then making sure that we're constantly engaging our partners. Meetings was one way, but also creating time outside of meetings that we just continue to engage as individuals who enjoy doing this work, but also enjoy just working together and building those relationships. Another challenge was the diverse representation. It was challenging for us to actually get funding because we continue to get response back saying that because so much diversity in the African immigrant community, that you're not going to be able to sort of identify an intervention that works. So I want to end by just acknowledging that we do have an HIV Awareness Day for African immigrants. It's called NIRA Day, National African Immigrant Refugee HIV and Hepatitis Awareness Day. It's celebrated on September 9th. We've been doing this since 2014. And so I really hope that folks on this call get engaged with this Awareness Day and really figure out how to celebrate this Awareness Day locally in collaboration with your local African communities. If you want to contact me, or if you have any information or questions around Tulumbe, here's my contact information.
Thank you, Chioma. That presentation generated lots of chat. And so I hope we get to some of these questions. So we'll give you a moment to kind of like take all that in. Our next speaker, Meloso.
Hi. Yes. Hi. Can you hear me all?
Yes, we can hear you, but there is your, yeah, there you go. And just put it in presenter mode.
Just, just a second. All right. Hi. Is the presentation visible?
Yes, the
Hi.
presentation is visible. We can use this format. We'll use
Okay. Uh, Hi. I represent African Services Committee Inc. in New York City in Harlem, and the agency provides. Let me see. Uh, Bear with me. So African Services was established in 1981 by an Ethiopian refugee to provide uh, general assistance to refugees coming in the 80s specifically from Ethiopia, and we have expanded to serve African and Caribbean immigrants in New York City. We serve about 7,000 immigrants and refugees each year, and we have a staff of 40 representing 20 countries with a multitude of languages spoken. Those include Amharic, Bambara, Haitian, Creole, Kiswahili, and so on. We provide health, housing, legal, and social services with an emphasis on HIV prevention and care. And these services are provided in a culturally appropriate manner and to promote healthy and independent living. Our programs include HIV awareness and outreach, testing, and COVID vaccine. And these days, we also provide COVID vaccination and navigation assistance, care and support for people with HIV. And one of sort of the critical services is accessing care, where we provide a patient navigator uh, to provide individual escort to hospital and primary care visits. And that is critical in a sense. Most of the clients do not speak English fluently or not able to navigate the complex healthcare system. So this one-on-one navigation services is critical to have healthcare needs of the population addressed. And we also have housing assistance programs where we provide actual identify housing and with other providers assist with rental assistance for a limited period of time. And with the housing assistance as well, sometimes there is also legal issues that come with that the clients face. So we have also a legal program that provides housing or immigration or any kind of legal services that clients might have. In addition, we have a food pantry program that's open to everybody, and individuals can come and pick up food pantry any time of the day as long as we're open. And in the evenings, we hold ESL classes for individuals who do not speak English. The care and support services, as I mentioned earlier, we do HIV, STI, hepatitis, TB, and now COVID testing, as well as navigation and retention to care, partner notification where necessary, and risk reduction counseling. For those who are positive and require psychosocial assistance, we have a case management program, and who might present with, again, as I mentioned earlier, legal needs. Our legal services will take care of those needs. And the housing program is open to those who are eligible. The housing program is funded by HUD, by OPWA, and it's specific to people who are HIV positive. The nutrition program is open to everybody, as I mentioned earlier. And we also have had an anti-stigma initiative addressing stigma around HIV that was funded by the Department of Health, and we have had it for about 3 years. We haven't had a stigma programming recently, but we do work with individuals who might face stigma around HIV and discrimination through our legal program. The case management program, we have two kinds of case management program. One is a single, one is family focused. For those who are family focused, that addresses the whole family, including children who might have been impacted by the primary caregiver. And these services are provided in a linguistically appropriate manner. Staff who are in these programs are not only from Africa, they also speak the same languages, and it tends to build rapport and trust among the clients. As I mentioned earlier, there's also the patient navigation service for individuals to access medical care, to either primary or acute care, where a patient navigator will actually escort individuals to make medical appointments, as well as provide escorts to their clinic visits. The barriers to healthcare is primarily most of the clients we provide services are uninsured because they are self-employed or they have small businesses and they cannot afford to get private insurance. And one of the other issues is legal status and the ability to work. The majority of the clients might not have legal status to access benefits. In terms of the diversity of the clients, as you can imagine, Africa has 55 distinct countries with over 2,000 languages. So as Chioma mentioned, it's like African immigrants are not one big population, like they are very diverse, and they bring with them nuanced cultural, language, and political backgrounds that are not the same. And usually African immigrants are lumped with African Americans, and you lose the nuances within the African population. And the biggest issue with African immigrants who are trying to to provide services, support to their families, such as their priority need is to provide shelter, food, and clothing for their families, and they tend to sort of not focus on the preventive health. So one of the issues around sort of health services is mental health. As you can imagine, the population, a good portion of the populations we serve come from areas where there was political instability or war, and they bring trauma to the table, and primarily the trauma needs to be addressed before they can actually get engaged in what would be considered a normal sort of peaceful life. So engaging individuals in mental health has been a challenge because mental health is stigmatized in our population. I mean, generally, mental health is sort of the orphan child, and it's been stigmatized. It's not addressed as a priority area. And most of the clients, even though we do screenings and there is an indication of a mental health issue, they are unwilling to engage with mental health services, especially in the sort of the hospital setting. So what we have is a mental health counselor who's French speaking, and they provide the services on site here where clients feel comfortable and safe. And having that safe environment here at African Services goes a long way in terms of engaging as well as providing the needed mental health services. the current issues sort of clients have a sort of during the pre-Biden administration, huge anti-immigrant environment had a huge impact on our clients, where they were to the point where they were worried in terms of leaving their house or dropping their kids to school or a hospital. And what you hear in the news coverage wasn't encouraging for the clients. And some of our clients have had personal encounters with ICE, and the discussion of public charge during that time has been an issue where people were concerned, like how they would impact on their future if they were going to be charged with a public charge, how it would impact their future residency status within the US. What we can do as providers to African immigrants is advocate for the less engaged communities and to empathize. If I was in their shoes, what would I do? And that sort of is the primary driving force at African Services. It's to empathize and see where our clients are and do our best to lessen the burden that they feel. Also getting involved in pro-immigrant advocacy groups, as well as, this is one of the primary points, is engaging in research that's focused on African immigrants and translating it into policy initiatives. And that's my presentation. If you have any questions, maybe we can get back to during the Q&A session.
Thank you, Meloso. Thank you so very much. Again, you are welcome to and encouraged to place in the chat box any specific questions that you have. We'll move to our next speaker, who will be Dr. Yvonne Commodore Mensah. Dr. Mensah.
Yes, thank you so much, Al. And Meloso, if you could please stop sharing. Thank you.
Okay, just give me a second.
What's exciting is to see all the speakers from around the US who are chatting in resources in their communities. We see Jeffrey and others that are chatting in information about work in St. Louis, Missouri, and we're hearing from New York and California. So this is an absolutely amazing opportunity for networking as well.
Great, thank you so much,
Meloso.
All
right.
Thank you.
Great. Let's see if I can pull my slides up. Can you see my slides?
Yes, we can, if you would enlarge them.
Okay. Do you still see it in presentation mode, or?
Yeah, it looks like it's in presentation mode, but it's really small.
Interesting. Okay, let's see if I can reshare and do something different.
Okay. Theodora says she's loving these presentations. I am too. I'm sure all of us are. That's great. That's it.
Is this better?
Yes, ma'am. That's
okay.
Great.
Sorry about the technical issues. Hello, everyone. I'm Yvonne Commodore Mensah. First, I'd like to thank Al and CCPH and the panelists for the opportunity to share space to talk about African immigrant health. I'm going to focus my presentation on improving the heart health of African immigrants through community engaged research. So my objectives are to first describe current research on heart disease risk factors and the heart health of African immigrants in the US, but I'll also share some lessons that I've learned and lessons that I've learned with my research team in engaging African immigrants in community engaged research. So I come to this work as a Ghanaian immigrant. So as was alluded to in the chat box, sometimes the word immigrant can have a very negative connotation, but I'm proud to say that I'm a Ghanaian immigrant residing in the US. I came to the US in 2004. I've lived in New Jersey. I've lived in Maryland. I've lived in Atlanta, and these states are home to millions of African immigrants in the US. So I think the point has been already made, which is that traditionally data on Blacks in the US are aggregated. So whether you're African American, Afro-Caribbean, or African immigrant, data are aggregated. And in terms of racial disparities, we have traditionally approached it from the perspective of looking at skin color, right? So as a doctoral student, I was just curious to know if there was any data on the heart health of African immigrants in the US. And I was surprised to find very little, to no cross-sectional studies describing the prevalence of hypertension, diabetes. And a lot of this work is inspired by conversations that I've had with African immigrants in the community. So one example is I went to an African store to buy goat meat. I'm a goat meat lover. And I was talking to the butcher, and I asked him, you know, how he was feeling, if he's seen a provider recently. And he said to me, Yvonne, I trust my body to tell me when I'm sick. And I asked if he had ever had his blood pressure checked in the US, and he had resided in the US for about 10 years and had never been to the doctor and relied on his body to tell him if he had hypertension or any other condition. So this really inspired me to take on this issue to see what the prevalence of heart disease risk factors are in the African immigrant population. So while we were planning this study, my colleagues and I wrote a commentary, essentially encouraging researchers to refrain from lumping data on Blacks in the US, but also in addition to exploring HIV, tuberculosis, and other infectious diseases, it's important to also address non-communicable diseases, to address mental health, to address the cardiovascular health of African immigrants in the US. So I think this should also be well known to almost everyone in the audience, which is that the African immigrant population in the US has grown substantially in the past 5 decades. In the 70s, the population was estimated to be about 80,000. But according to the US Census in 2015, there were at least 2 million African immigrants in the US. And many people will tell you this is likely an underestimate of the true size of this population. I can tell you this may actually be the size of the Nigerian population in the US. So we really don't have an accurate count of the African immigrant population in the US. So the African immigrant population in the US actually reflects the rich diversity of the African continent. And Malusu made this point earlier, but Nigeria, Ethiopia, Egypt, Ghana, and Kenya make up the top 5 birthplaces for African immigrants in the US. So the other point to be made is that the African immigrant population is also not homogenous, right? So there are different countries represented, different cultures, different languages, right? So we need to address this issue from an ethnic perspective also, and not assume homogeneity in terms of heart health of African immigrants. So now I'll transition to also share some data on what we know about the heart health of African immigrants in the US. One of the first studies I conducted was called the Afro-Cardiac Study. So I embarked on this journey as a doctoral student to try to understand the cardiovascular disease risk of African immigrants in the US, but also look at the role of acculturation. So for those of you who are familiar on research on immigrant populations, acculturation is a popular concept, right? So how does health change based on length of stay, but also how people identify, right? and how does that associate with cardiovascular health. So this was a cross-sectional study. It was conducted between 2013 to 2015. We recruited participants from 7 churches in the Baltimore, Washington, DC area, and we only included people who were African immigrants who were born outside the US, not second generation, first generation immigrants. And we used convenient sampling because we didn't have a sampling frame or a list of all African immigrants to be able to randomly select people to participate. However, when we recruited participants from churches, we realized that it allowed us to recruit a diverse population. So there were bankers, accountants, cab drivers, right? So churches don't discriminate and limit participation based on socioeconomic status, for instance. And we included adults ages 35 to 74. And we selected Ghana and Nigeria as the target countries because they make up the larger segment of the African immigrant population in the metropolitan area. And we excluded participants who were pregnant or were born in the US or another African country. So we learned a number of lessons in this study. The first is that the African immigrant population is highly educated. So at least 60% had at least a college degree. And this is much higher when you compare it to the US. Only about 33% of the population has a college degree. However, this high level of education did not necessarily translate into higher income, right? So only 36% of the 253 participants had a household income greater than $50,000. So many of us know cab drivers who have master's degrees, some have doctoral degrees, and are not really using their degrees and are, because of their status in the US, they may be employed in other fields. So the lesson there is also that education is not a reliable proxy of socioeconomic status in the African immigrant population, because people may come to the US with advanced degrees, but may not be using them to actually work. Another lesson we learned was that only 52% of the participants had health insurance. And I have to acknowledge that this study was conducted right around the time of the implementation of the Affordable Care Act, right? So, but in this study, only 52% had insurance, which is much lower compared to the national estimates at that time, which was about 82% being insured. So what were some of the risk factors we observed? So the good news is that only 1 person reported smoking. But again, because we recruited participants from churches, there might be some bias there, right? Social desirability bias. But then we also observed that obesity was a highly prevalent condition. 88% of all the participants were considered to be overweight or obese, right? About 40% had hypertension and 17% had diabetes. So we actually measured blood pressure. We used a point of care testing system to measure fasting blood glucose. We also measured cholesterol. So these three risk factors were highly prevalent in this population. I have to acknowledge that this study wouldn't have happened without my tribe, right? We say that it takes a village. And so I just wanted to acknowledge the team members who made this work possible. And all of our team members were volunteers, right? As a doctoral student, I had very little resources to pay people to help with data collection, but everyone listed on the slide volunteered time very early on weekends to go to these churches to actually collect data. So the next study we conducted was the African Immigrant Health Study. This was similar to the Afro-Cardiac Study, but the difference is that rather than just focusing on heart health, our survey included questions about physical function. We also included questions about screening for cancer, right, and other health conditions. But in addition to broadening our scope, we recruited African immigrants from Liberia, Sierra Leone, and Cameroon, in addition to Ghana and Nigeria. And so one of the findings we observed in the African Immigrant Health Study is that social determinants were associated with hypertension and diabetes. And this paper, which is published in Ethnicity and Health, was led by Bunmi Ogungbe, who is actually on the call with us today. If you have any questions, please feel free to pose them to Bunmi. But one of the findings was that people who were unemployed were more likely, about 5 times more likely to be diagnosed with diabetes than people who were employed. So in a separate analysis that was led by Ruth Alma Turkson Okran, who's also on the call, we also observed that discrimination was associated with having at least 3 cardiovascular disease risk factors. So those who reported higher levels of discrimination were more likely to have at least 3 cardiovascular disease risk factors. And so when we conducted these 2 studies, one of the questions we got over and over again was, so what are you going to do with this information? Are you just going to come collect the data and just disappear? And we kept saying that, we're hoping to use this data to lay the foundation for community-based programs to actually improve the cardiometabolic health or the heart health of African immigrants. And so thankfully, we're able to apply for some funding from the National Institute of Nursing Research through a pilot grant. And we were able to design a program called the Afro-Dpp Program. So some of you may be familiar with the DPP program, the Diabetes Prevention Program, which is a national program that is thought to prevent the progression from prediabetes to diabetes, but also improves blood pressure, reduces body weight. So we wanted to adapt this for the African immigrant population. And this study is still underway. We are getting ready to start recruitment, but the purpose is to determine whether a virtual, culturally tailored lifestyle intervention, which includes remote monitoring of blood pressure and body composition, actually improves blood pressure, improves body weight, BMI, or body mass index in African immigrants. And so we're going to have 2 groups in this study. The first group will start immediately and they'll get a lifestyle intervention with a lifestyle coach who's actually an African immigrant who has a good understanding of the different diets and how to adapt them, but also ensure that they're nutritious and help to improve heart health. And the second group will get a blood pressure device that's shown on this screen, but also a scale, right? So they'll get those devices, but they won't work with the lifestyle coach until 6 months into the program. But the first group will start with a coach, get these devices, and we want to compare the findings between both groups to see whether, in addition to having these devices, working with a lifestyle coach actually goes a step further to improve heart health. And so we've done some prep work. One of them includes developing a study brochure, which was actually co-developed with some medical students, nursing students. So we took an American Heart Association brochure and actually adapted it for the population. And so that's shown on the screen. But this program will include 5 research study visits. So participants will have their blood pressure measured, their body weight, but they'll also have curriculum sessions that will be led by the lifestyle coach, right? And each participant, like I said, will get a free blood pressure device, a free digital scale, right? That will allow us to monitor their blood pressure and weight throughout the duration of the study. And so I just wanted to share some lessons that we've learned along the way briefly. And some of these lessons have been described in 2 commentaries. The first is published in Ethnicity and Disease and is titled Engaging African Immigrants in Research, right? And I'll describe some of these lessons shortly. And the second is specific to engaging or recruiting African immigrants for community-based cancer prevention studies. And so this was led by a colleague, Dr. Joycelyn Cujo. And so if you want to learn more, please refer to the article. So one of the first lessons we've learned is that building trust is paramount. So even though I'm an African immigrant, I didn't want to assume that the community would be open to this research and would embrace me with open arms. I had to do my homework. I had to spend time engaging with the community leaders. I had to be transparent about why we were conducting these studies. I had to explain why people should participate in research in the first place. People said, I didn't want to be a guinea pig, right? But I had to take time to explain why we're conducting research, the risks, the benefits. I also had to spend time engaging with the community leaders to explain the studies. And as soon as I got buy-in from the leaders, that made things much easier. So that these leaders gave me the platform to address the congregation, to recruit them from the study. And then ensuring that the team reflects the target population. I've been very lucky that our team consists primarily of African immigrants who are doctors, nurses, students who are really passionate about this work. And Maluso referred to this earlier, which is that immigration status is an issue, right? So there are people who are concerned that their data would be shared with immigration ICE, and we have to actually explain that the data would only be used for research purposes. And in the African Immigrant Health Study, we didn't even ask people for their names, right? And people felt more comfortable knowing that they could complete the questionnaire and not reveal their identity. And then we also use oral consent to make people feel a little more comfortable with participating in the study. And so I actually alluded to this religious consideration. So in the AfroCardex study, we only recruited people from churches, but in the African Immigrant Health Study, one of the feedback we got was that, you know, there are also Muslims who are African immigrants, so we need to also broaden the target population. So we recruited African immigrants from mosques in the Baltimore, Washington, DC area. And when we visited these mosques, we had to observe their practices. We had to don a scarf and make sure that we were being respectful, right? And then in terms of logistics, this can be really challenging. Collecting primary data is time intensive, resource intensive, right? But there are ways to ensure efficiency. So for instance, if you have a survey, you can put the survey online so that people can complete the survey in advance in the comfort of their homes, so that when they show up to the church, for instance, you may only measure their blood pressure, height, and weight, for instance. And like I said, ensuring that the team is competent and is diverse. A lot of the participants were excited to see, you know, team members who also spoke their languages, so they felt comfortable speaking Yoruba, Twi, and other languages with the study team members. And social media, we've used WhatsApp. So a lot of African immigrants belong to at least 5 groups on WhatsApp. Take advantage of those platforms to disseminate information on your research projects. And lastly, fostering long-term partnerships. So one of the best advices I've received so far is that, you know, you give before you get. Right. So as I've engaged with a lot of these churches, I've had to give presentations on heart health. Right. I've had to offer myself and gladly as a resource to the African immigrant community. So you have to be willing to offer your services to the community and not just take from the population. And then stay connected with the community. So when we got the opportunity to apply for funding for the Afro Dpp program, because I had maintained contact with these churches, it was easy to go back and say, remember us? You know, we were here a few years ago, we collected data. Now we have an opportunity to actually do something about, you know, the high prevalence of hypertension and diabetes and obesity in this population. And so with that, I'd like to say thank you, and I'm happy to take questions.
Thank you, Dr. Commodore Mensah. That was an amazing presentation, and it generated, again, lots of information and questions. So you see Dr. Commodore Mensah's contact information. We'll share that with you as well. We will also share the slides. And so take a moment there and breathe. We'll give you a moment to breathe. I'd like to go start back with Chioma. Chioma, there were some questions in the chat box for you as well. And so I want to, now that you've had a few minutes, I want to just pose a couple of questions to you, and then we will move with the other presenters. In particular, Chioma, one of the questions was, in the data that you presented, were these first generation US born Blacks data separated out from other US born Blacks? And if so, was there any significant difference?
So I'm not sure which data, is that the national data?
That was the national data that you presented?
Yeah, so typically the variable or the indicator that's used around identifying where either first or second generation is country of origin. And so these are all individuals who were born on the continent, in a country, in an African country. So they're not second generation, who are individuals who were born here and have at least one parent who is an African immigrant. I think that it will be interesting to start looking at data related to first and second generation. I know a couple of colleagues who have started sort of to tease that out because there is, some suggestion that second generation are definitely experiencing health inequities in the ways in which non-US born are experiencing. I know from my own personal experience, when we talk about second generation, we're talking about individuals that are sort of on both sides of the culture, right? So, and how that impacts us being able to engage in the American system, but also hold on to some of our own cultural values. So I definitely think that that is another direction in which research can go for African immigrants, really looking at the differences between first and second generation.
Thank you. Another question related to your presentation, Chioma, was that individual said, I'm curious why immigrants seem to be getting infected post-immigration, and since most infections are for heterosexual relationships, is there some dynamic that is behind this?
I think, I think that's an interesting question. And just, anecdotal, nothing that has been, scientifically looked at, but anecdotal, and just, in my own programming and advocacy work, there's this idea that once African immigrants come to the US, they're no longer at risk for HIV, right? Because we know that in a lot of African countries, the prevalence is very high. And so once we come to the US, you don't really hear about HIV in the way that you hear about HIV in some African countries. And so folks feel like they're not at risk. And so they're engaging in relationships and other, practices that might put them at risk with populations, and not really, and with US born populations, and not really thinking about what does it mean to prevent themselves. And I said US populations, but also within their own communities, because just overall Black folks, US born or non-US born, have a closed sexual network. And so we have relationships with people who look like us. And because the prevalence of HIV in Black communities is so high, there's a higher probability that you're going to get exposed, right? And so I think there are various factors that make it so that when folks come here, they end up getting infected post-migration.
Thank you, Chioma. Well, also, we'd like to see your face. So would you turn your camera on? We have a question for you as well. So someone had a specific question regarding your organization. That question was, Juliet said, do you also serve undocumented immigrants as well in the work that you're doing in New York? Yes, we can't hear you. So if you'd unmute yourself, please.
We're open to anybody. So legal status is not an issue. We're here to help. In fact, majority of our clients are undocumented or out of status.
Yeah, Maluso, I have a question for you in that you talked some about the work that you're doing around COVID-19. I'd like to hear more about that work, and just are you beginning to, have you collected some data regarding incidents of COVID-19 in some of the communities that you serve? Do you have some data there?
We haven't collected the data specifically to African immigrants, but anecdotally, it's people, clients have had a hard time navigating the healthcare system to get the COVID vaccines. So what we do is we have set up a telephone line, and clients who need assistance, we provide either in-person escorts or give them the address where to get COVID tested. And now New York City has expanded COVID testing pretty much on demand. So the issue is language and ability to navigate sort of where to go and how to get vaccinated.
Okay, thank you so much. Dr. Commodore Mensah, there was a question for your presentation. It's a great study. Why did you segment the population in your study to those between the ages of 35 and 75?
Yes, thank you. So I believe the question was regarding the Afro-cardiac study.
I
So
believe it is.
we calculated the what we call a global cardiovascular disease risk score, the Framingham risk score, right? And that is validated for people between that age group. And so we included that in our inclusion criteria to make sure that, for instance, if we included an 80-year-old, the risk score that we generate wouldn't be as accurate as those in the 35 to 75 year group.
Yeah. So specifically regarding, you mentioned trust being and trustworthiness being critical elements to engagement. I'd love to hear more about some of the additional strategies. You talked about working with pastors. Or did you also find some community leaders that you were able to work with as well, kind of outside of maybe some of the religious settings that you were, faith communities you were working with?
Yes, no, that's an excellent question or point. So I also happened to be part of a group that plans an African immigrant health conference, usually yearly, but we know COVID has disrupted a lot of things. And so there are community leaders who are part of the steering committee. So I've been able to engage them in the process and advise them, actually ask for advice in terms of recruiting librarians, for instance, right? So I had easier access to Ghanaians because I'm Ghanaian, right? But for the different groups that we wanted to recruit, I had to really tap into that resource to ensure that I knew where the Liberian churches were, for instance, right? Where the Liberian community organizations were. So I've been very fortunate to be part of a network that sort of is beyond sort of the religious setting, but is doing a lot to advance the health of African immigrants.
Thank you. I'd like to
Yes.
engage now in kind of a rapid fire response from each of you. So I'm thinking about questions, and that is like, if you had to do a 30-second elevator speech around why it's so important to engage the African immigrant community in research, what would that be? Chioma, take it away. 30 seconds.
Oh, I need 30 seconds just to think about my answer.
I'll give you a minute. I'll give you 30 seconds to think about it. So Moloso and Yvonne, you have more time. So you better get those answers ready. Why should African immigrants be engaged in research? Come on.
Well, I think overall, I mean, for me, I do community organizing, and I am, very clear about the importance of a community voice, right? And doing the work. And what I found is people continue to put things out there in terms of programs and interventions, and then they ask, why aren't African immigrants coming, right? And it's because you have not engaged this community in really what makes sense. There's another project that we're doing that is a regional project with 6 other states, New England, 6 states, and it's focused on COVID-19. And so we did a Photovoice project with that. And what actually was revealed is that people want to learn or have research around traditional African medicines and traditional foods, right? So we're talking about COVID-19, right? And our community is talking about, no, we actually need to be talking about, right? So, I think the critical piece is, if you really want people to be healthy and to be well, that you engage them in their own wellness, right? And their own wellness and what's important to them. And so I think that's what is critical about us making sure that we create environments in which health is the default and people really can be well.
Thank you. Moloso, go. Why should African immigrants be engaged?
Yeah, to add to Chioma's point, I mean, we need to collect the data. We need to show that African immigrants are here and these are their needs. And if we don't have the data, we can't sort of make the argument for any change, policy initiatives. So it is critical that we collect the data and show the research and show the need so that we can advocate at the policy level. Africans are here, this is the data, this is the need, this is the gap.
Thank you. Dr. Commodore Mensah.
I'd only add that stories are compelling, right? But in terms of applying for grants, stories do not win grants. We need data to be able to make a compelling case for why we need to address the health of African immigrants. It would be nice to say my uncle had a friend who died suddenly of stroke in New York. He was an African immigrant. He didn't have health insurance. That's a compelling story, but they want to see numbers. They want to be able to see how funding will have an impact, right? And numbers are also compelling. And if we want to be able to design programs that improve the health of this population, we really need data, but data that is also generated through collaborating with the community.
Yeah. Well, so I want to.
I'm sorry, Al, if I could just expand on that, on this conversation around data. I have a love-hate relationship with data, right? And I think part of it, part of it is because we are using variables that are not necessarily reflective or applicable or have been tested, right? Valid scales that have been tested with African immigrants. And so, part of what I, try to aim for when I'm doing, collaborative research is to really think about what are the variables that we're using and are actually capturing the stories of our community, right? And there's certain variables that I always include, right? I always include immigration questions. They're critical because we know immigration is a social determinant of health. And so we need to be able to capture that for our communities. I'll always include questions around language because we know language can open the doors, and language can also create barriers, right? And so really thinking about what are the preferred languages that people want to hear their information and learn, but also what are the various languages. African immigrants come multilingual, not bilingual, but multilingual. And so part of my challenge around data is that we don't have the right variables even to capture what's happening in our community. So as researchers, whether we're in community or in the academy, I want to encourage us to think about what makes sense for this community in terms of developing our own variables and scales, and even challenging some of the scales that are out there that have been used for years and years and years and years, right, to capture various health indicators. So that's just my plug.
Thank you. I'm like acknowledge Theodora says, yes, language justice is so needed in response to your comments, Chioma. Oloso, I want to return to you because you really struck a note with me in terms of the emphasis on policy. What do you think are the critical policy issues or recommendations that really need to be advanced at this moment? What are some of those issues?
Simple example, if you are undocumented buying health insurance, if you have the money, it's not as easy. Even if people willing to get private insurance because they are undocumented, they are unable to buy insurance. No, I'm not saying insurance is cheap enough. Just at a simple level, your legal status decides sort of your level of access to healthcare. At a basic level, even buying insurance. So those are the policy issues that need to be addressed for African immigrants to engage in the healthcare system.
Oh, thank you. Dr. Commodore Mensah, what about you in terms of policy? What are some of the recommendations that you'd like to see move forward?
So one of the recommendations is to improve access to healthcare. So I alluded to the fact that a large segment of the population remains uninsured or underinsured, right? So when you think about the context from which a lot of African immigrants are coming from, you don't pay for health insurance. People only go to the provider if they're sick or dying, right? And so when it comes to the US, we need preventative services within the community that are not tied to health insurance, that are community-based. And we know that there are a lot of ethnic enclaves of African immigrants. If we can have community federally qualified health centers within these contexts, right, that provide preventative services. So screening for hypertension, diabetes, to actually prevent heart disease, to prevent strokes, kidney disease, which we know are increasing in this population. But unfortunately, we don't have reliable data, right? So we need preventative services that are not tied to insurance status.
Thank you, Dr. Commodore Mensah. Chioma, I want to pose a question to you that has kind of been recurring in the chat box, and that's around national organizing of disparate communities, right? So people are saying, what are those national movements that are afoot or already in place regarding organizing different African immigrant communities? And you work in that space a lot. Share with us some things there.
Yeah, I mean, there are several organizations that are doing national advocacy work. Undocu Black, I have to get the right name, where they actually have done amazing work and making sure that folks know immigration is a Black issue. Also, Baji is another organization. And these are organizations that specifically focus on immigration, right, and Black immigrants. We have started a collaborative coming out of New England, a national collaborative that's focused on research for African immigrant health. It's called the African Immigrant Health Research Collaborative. I can put the website, or my colleague can put the website in the chat. So that's another network that's being created to really focus on African immigrants. But definitely I can, as a follow-up email, hopefully CCPH can send out to folks, I can give a list of some advocacy organizations that are doing amazing work around immigration rights and immigration justice, and intersecting that with some of the some health issues around housing. I mean, of course, the issues around COVID-19.
Yeah, thank you, Chioma. So Dr. Commodore Mensah, I think I'm going to pose this question to you. Someone asked about, because I'm not familiar with it, is will there be another research workshop 101 for novice researchers? Are you familiar with that? I think that was directed specifically to you. Did you sponsor that, offer that recently?
No, I haven't, but I'm more than happy to talk offline with this person. Feel free to reach out. I think, working with others and learning from others' experiences makes the journey smoother, right? So there are a lot of lessons that I haven't been able to share because of time, right? But I think one of the things we need is to work together and collaborate to share instruments. So there are instruments that have been, for instance, validated in African immigrants. So knowing which instruments to use, right, is helpful. So there isn't really a formal structure to my knowledge, but I'm more than happy to talk to you offline if you'd like to learn more and want to embark on this journey.
Thank you.
I definitely think, Al, that's a place that CCPH could play in terms of supporting. I personally have to say, I'm very excited at seeing the number of African immigrants that are on this webinar. Amazing reach. I'm excited to see everybody, but particularly African immigrants who are committed and thinking about research within their community and dealing with health. And I think it's an opportunity to really start talking about what does it mean for us to build our capacity in our community to actually do the research, whether you're in the academy, whether you're, a faith leader, it doesn't matter where you sit in the community, but we all have a role to play in this work. And so I definitely think that because I know of CCPH's work, that capacity building within communities is their thing, right? And so it might be a conversation that we could have as a part 2 around how do we hold some type of research 101. I know Al is like, you put more work on my plate, but
second thing today already, Chioma.
But I just want to put that out there and just sort of my appreciation for folks who are on the webinar.
I think it's great. I mean, it's amazing that we have so many people still on the call. Hey, Dr. Commodore Mensah, I want to cue you up here in a minute to actually share more about the invited opportunities around some publications and additional research. But I want to just wrap up. I won't say 30 seconds. We've got a little bit less than that. But, oftentimes when you're presenting, you have something that you wish that you had shared. Musolo, what would, thinking back, is there anything that you missed, or would you just want to kind of a closing comment here as we end up today?
Yes, for those who work in nonprofits, and I'm sure a good portion of the audience works in nonprofits, is funding for nonprofits. Usually you write a grant, it's focused on the program. There is no funding available to do the research piece. It's usually like to do the research, you need like an evaluator, somebody to collect the data, somebody to enter the data and publish it. Usually, my experience is you get funded by government grants to do a specific service. There is no room to do the research. So engaging philanthropies, private philanthropies, especially African philanthropies, there are a number of wealthy African individuals who could take that space and say, okay, this is a needed area, we will fund it. So, but how do the nonprofits access those sort of larger philanthropies who have access to sort of larger resources?
Yeah, thank you. Dr. Commodore Mensah, I'd like for you to maybe just kind of end out today. And I'll give the last word to Chioma, and share with us about these opportunities around the abstracts and the publications.
Yes, thank you so much. So first, I have to say that like Chioma said, it's really exciting to see so many people on this call who are interested in this topic. I never imagined sort of this level of interest when I started this work about a decade ago. So to continue the dialogue, there's going to be an upcoming virtual conference on African immigrant health between September 8th to the 9th, and actually coincides with the Hepatitis Day and the NIRA Day. So the themes of the conference is removing systemic barriers and improving health outcomes in African immigrant communities. I'll put a link in the chat. And so this is an opportunity to attend the conference and also submit abstracts. So the abstract deadline has been extended to July 8th, or actually July 7th. So if you're doing any work addressing African immigrant health, please consider submitting your abstract for this conference. And the second opportunity that I want to share is there's a special issue on the health of African immigrants, the burden, determinants, and solutions by the International Journal of Environmental Research and Public Health. Again, I never imagined that there'll be a special issue dedicated to African immigrant health. So if you have any papers that you want to submit, the deadline is on November 30th. But you can submit earlier. So feel free to submit abstracts or your manuscripts for the special issue. And I'll add the links to these opportunities in the chat box for everyone. Thank you.
Chioma, please close us out.
Well, I just want to say thank you. I think I sort of gave my closing comments, and I'm very excited about the conversations that have happened in the chat. There's a lot of follow-up, I think, with us as individuals in terms of the panelists, but also as the Multicultural AIDS Coalition and CCPH work together on this webinar. I think we have some things that we want to talk about, and so I think how we can move things forward. So please take advantage of what has been shared in the chat. Please take advantage of all of our contact information. Connect with us. We are about building and doing this work together, and really thinking about, at the end of the day, how do we ensure that the communities that we love and that we reflect, African immigrants, are well here in the United States. So thank you, Al, and CCPH for collaborating with us, and we look forward to next steps.
Thank you, everyone.
Thank you, everyone.
Thank you.
We will share absolutely the information and compile it for you.